Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts. We are privileged to have the distinguished Professor Shadab Siddiqui, hailing from Virginia Commonwealth University. He is renowned for his profound contributions to the study of steatotic liver disease and liver transplant. In today's episode, he shares about his groundbreaking research on the natural history of NASH cirrhosis in individuals awaiting liver transplants. This remarkable study was recently unveiled in the esteemed Journal of Hepatology. Let's welcome Professor Shadab.
Okay, so thank you so much, Prof. Shadab, for joining us today. So, Prof, do you mind just sharing with us about what you do and what your interests are?
Sure. So thank you, Chang, for having me, inviting me for this podcast. My major interest is around liver disease, and more specifically, non-alcoholic fatty liver disease or metabolic associated steatotic liver disease. And I started off with a focus in cardiovascular disease in fatty liver, and then over time that interest evolved into more metabolic diseases, biomarker development, and with a major emphasis in how NASH or MASH affects liver transplant and what happens to these patients after liver transplant. So a number of my research priorities is trying to better understand what happens to these patients as they have gotten end-stage liver disease or they're dying from it. And if they're lucky enough to get a liver transplant, what happens to them after the transplant? And what are opportunities for clinicians to actually make sure that these patients do better than how they have done historically? So those are my that's what I've been doing in the past couple of years.
Right. I mean, we did quite a few studies around the area. So just want to check, like for instance, the one that we just recently did in Journal of Hepatology, where we look at how the different how NASH is different in NASH cirrhosis is different in transplant compared to other etiologies. I was just wondering when you can bring us through this study and how just run through with us like how it's different.
Yeah. So Chang, what's happened over the last, so the way we approach who gets a transplant and who doesn't, for the vast majority of patients, it's how sick they are based on their MELD score. And the idea is that patients who get sicker, their MELD score goes up. And when their MELD score goes up, they get a transplant, because higher the MELD score, the higher the likelihood that patients are going to die in the near future. Now, this was developed and sort of validated in the era of alcoholic liver disease as well as viral liver diseases, so hepatitis B, hepatitis C. But over the last 10 years, the number of patients who have viral hepatitis has gone down drastically, and patients who have NASH has gone up drastically. So much so that now MASH is the leading reason for liver transplantation among women in the United States, as well as people over the age of 60, 65. So the big question is, do all liver disease behave the same way while these patients are waiting for liver transplant, meaning they get sicker and the MELD score goes up, and then what component of the MELD score actually goes up in different patients? Because if, as most people know, patients who have alcoholic liver disease or if they have viral hepatitis, they look very different than patients who may have MASH or fatty liver disease, because patients with fatty liver disease are more likely to have diabetes, they're more likely to have hypertension, obesity, and so on. So what we wanted to do is answer that question: is how do these patients behave while they're waiting for a liver transplant, and is the MELD score appropriate for them? So what we found is that patients who have NASH cirrhosis compared to other reasons for cirrhosis, their MELD score doesn't correlate or doesn't associate well with how sick they are. So generally, they have more burden from their liver disease or cirrhosis or portal hypertension, even at lower MELDs when you compare them to other causes. And then, unfortunately, most of patients with fatty liver disease are getting listed at a much lower MELD score than other causes of liver disease. And when they actually get MELD largely had three components up until recently, which is kidney function, bilirubin, and INR. And patients with non-NASH cirrhosis, what drives their likelihood of a liver transplant is increase in bilirubin, which can increase substantially. Unfortunately, bilirubin doesn't increase that much in patients with NASH. They actually have to go in renal failure for them to get a liver transplant. So this is a very different way of thinking about it. And when we look at what is the impact of this change in MEL score as it affects transplant probability, patients who are listed for liver transplant with NASH or MASH cirrhosis, they're less likely to get a liver transplant, almost 15% less likely. And then more importantly, they're actually similarly about 13% higher risk of dying while they're waiting for liver transplant when compared to other causes of liver disease. So they really are disadvantaged while they're waiting for liver transplantation. And I'm hoping that as the new MEL score gets implemented, that this is going to make things better for patients with NASH. One of the things that our study highlighted that we did together, Changhan, is that it highlights the disparities in transplant allocations as well, because women were even less likely to get a liver transplant when compared to men. So not only is there a drop-off in patients with NASH, that drop-off is even more steep in women. So I'm hoping that as the transplant community implements the score, that there's going to be some equity in organ distribution in the women.
Wow, okay. So in terms of like women, I think the new MELT 3.0 does include gender as one of the factors, if I recall correctly. So maybe with the introduction of the MELT 3.0, I think that's something that we can look at as to how the NASH cirrhosis may be better educated, like you mentioned before. So in terms of like, how about longitudinal outcomes? In NASH patients, does the surveillance and risk factor profile, is it similar between NASH and non-NASH?
So it's actually different. And so let's start at the top. When you take a patient with NASH cirrhosis and they get a transplant, there's lots of things going on in them compared to other causes of liver disease. They're more likely to be diabetic, almost twice as likely. They're more likely to have hypertension, cholesterol. They're 2 times as likely to, or actually 4 or 5 times as likely to have heart disease compared to alcoholic liver disease, which is the other common cause of cirrhosis in patients who get a transplant. So these patients are different to begin with. And just because you fix their liver, you're not fixing rest of the problem. So you're taking the bad liver out, you're putting a good liver in, but the kidneys are not working, the pancreas is not working, the heart already has issues to deal with. So what happens to these patients is very quickly after liver transplant, they start to get in trouble because rejection medicines tend to make all of those things that I just mentioned worse. So within the first year to 2 years after liver transplant, these patients gain almost 2, sometimes 3 times as much weight as patients who are transplanted for other causes of liver disease. And almost everybody who got a transplant for NASH cirrhosis gets fatty liver disease back. Whereas patients who get a transplant for other reasons, it's about 30 to 40%. So it's a lot less. And if we were to implicate that this happens because because of the rejection medicine, then you would think the numbers are similar, but there's actually a difference between the two. So it suggests that there's pre-existing risk that gets worse with the transplant. And more importantly, if you look at patients who get fatty liver disease in the general population, meaning people who've never had a transplant, it takes roughly 30 to 40 years for these patients to go from having no damage in the liver to cirrhosis of the liver. So roughly 30, 40 years. And however, after transplant, they can get cirrhosis within 5 to 10 years, which is scary. And 20% of patients who get a transplant for NASH cirrhosis actually get advanced fibrosis. So stage 3 or stage 4 fibrosis, 20 to 25% will have it within 5 to 10 years. It's actually somewhat scary.
Yeah, that's
because
high.
yeah, because we don't think about it, and The reason why, this problem somewhat gets under recognized is because the number of patients with NASH or fatty liver disease is roughly in America about 100 million people, but patients who get a transplant is roughly 12,000 patients in America get a transplant per year. So the number of patients is less, but you have a disease that's severely accelerated. So it's only now that we're starting to recognize some of these things, and we're actually putting together more guidance on how trials should be done, how we should approach post-transplant fatty liver disease with the hopes of actually having transplant-specific drug development and biomarker development efforts.
Wow, okay. So I think another thing that we kind of did was looking at how heart disease pre-transplant and post-transplant affects the mortality. I guess that burden will largely be higher in patients with NASH, given that they have significant cardiovascular burden to begin with.
Yes, so that's very true. Generally, patients with NASH, their cardiovascular disease is accelerated rapidly. And in the paper that we did together, it shows that the pre-existing cardiovascular disease has significant impact on post-transplant outcomes. And more importantly, patients with NASH are generally worse off than non-NASH. And this has to do with a couple of things. One of them is that when you take a liver and you put it into a patient with NASH, and within a year they get fatty liver disease back, the liver changes and it adapts. And when this liver changes, liver makes cholesterol. So liver is a central organ in cholesterol or lipid metabolism. So it starts to make these larger and more atherogenic VLDL particles, which tend to stay in circulation longer. They tend to get metabolized differently, and they get converted into small dense LDL. And this is really the major bad type. And we looked at a whole host of different biomarkers, lipoprotein-based biomarkers, and small dense was the key one that actually was associated with prospective cardiovascular events. And the reason why is because small dense LDL has lower affinity for LDL receptor. So it doesn't get taken back up. So this tends to spend more time in circulation. It's also smaller in size. So because it's smaller in size, it tends to get absorbed into the endothelium more readily. And when it gets into the endothelium, it's more likely to elicit a reaction and an inflammatory cascade. And so it causes plaque rupture. So you can see it actually promotes the whole pathway of atherosclerotic disease. And since NASH patients have all the prerequisite, it tends to be more accelerated. It certainly happens in most transplant patients, but NASH is far worse than other patients.
Wow, okay. So we talked about the fact that most patients, a large majority of patients with NASH transplant can develop fibrosis after transplant, getting back their NASH again. So what are the strategies then to detect this, and how do we monitor? Because I don't think there's any good studies out there that show biopsy proven analysis of or should I say large-based studies to show biopsy proven with non-invasive tests as a comparator for screening for fibrosis.
Yeah, so you're absolutely right. There is no study specifically in patients with transplanted for NASH cirrhosis because the numbers are smaller. So in order for you to do this validation study, you would have to have a multi-center involvement where patients get biopsies. But we've actually published now 4 or 5 papers on the utility or use of FibroScan as a way of assessing fibrosis and risk stratifying patients. And we've been able to use different approaches to not only detect fibrosis, but also improve on the diagnostic performance. So historically, fibrosis, all of this tests, non-invasive tests, they have a high negative predictive value, but a low positive predictive value. But we've developed clinical algorithm using sequential approaches where you can classify about 80% of patients with almost 95% accuracy. So I think there are certainly tools there in the transplant setting. It's just that they haven't been validated specifically in patients with fatty liver disease.
Yeah, I was also I was just wondering, thinking aloud here, I'm not sure whether Agile 3, Agile 4 might be used in patients with NASH cirrhosis after.
Oh, no, it doesn't work. We actually did that study.
Oh, okay.
So, and the reason for that is simple too, because we actually showed that in patients who have transplant, they get put on rejection medicine, the thrombocytopenia, splenomegaly, that doesn't always improve. So the platelet counts tends to drop. So most of the patients have low platelet counts, and platelet count is an integral component of Agile 3 and Agile 4. And then the risk of diabetes is overrepresented in transplant population. Their ALT and AST may not always go up and may not always follow the normal ratios that you see in non-transplant patients. So what that means is, Agile 3, Agile 4, FIB4, NAFLD fibrosis score, none of these are actually very accurate in transplant population. So you actually need a transplant-specific biomarker that actually or model that would actually help risk stratify these patients, because everything that you use in a non-transplant patient, it doesn't work. So to give you another example, age is an integral part of these scores, right? Because the idea is that it takes you 30, 40 years to get cirrhosis. So you're not going to see cirrhosis in a patient who's 15 years old most of the time, or 20 years old, or 25 years old. So that's why these scores are weighted more heavily for people who are in their 50s and 60s. But you may have a 60-year-old and you just put a new liver in them. So even though their biological age is 60, the liver has no disease in it at the time that they get a transplant. So instead of looking at how old they are, it may be better to look at when they got a transplant. It's very unlikely that somebody, despite their age, that they got cirrhosis within 2 years after liver transplant. However, if you have a patient who's 10 years out from transplant, they're more likely to have it. So instead of looking at age, it's better to look at the age after the time from transplant to when the biomarker is being deployed.
Wow, okay. Actually, that sounds like a study that we can potentially do.
Yes, there's lots of ideas, Hang on.
Yeah.
That's why we need such promising and young investigators like you to lead the field.
A bit tired right now, but yeah, we'll definitely do it. Actually, I think we already have like a lot of those data points. Is something that we can definitely explore. Like in reinventing Agile 3 for NASH transplant patients. But because the sample size is a bit smaller, would you design the study to be just specific for NASH transplant or like transplant in general?
Well, see, it's not necessarily NASH. It could be patients with fatty liver disease. But see, Cheng Han, the other way to think about it is, why do we care about fibrosis, right? In a non-transplant population, we care about fibrosis because fibrosis is a predictor of clinical events, right? So you're not going to do a study where you enroll patients in a clinical trial and then wait for 30 to 40 years for them to have an event. And the event rate is low. So you would have to enroll tens and thousands of patients over 30 to 40 years for you to have events, right? But in a transplant patient, it's very different. So you at 5 years, 40% of patients are dead. In 5 years, 20% of patients have advanced fibrosis. So you don't need to look at fibrosis as a surrogate marker because the patients are dying. So you actually have a hard clinical event. So you can actually skip the step of looking at fibrosis and go directly to hard clinical events such as cardiovascular disease, such as MI, such as graft cirrhosis, such as death. And I think so the biomarker development in transplant patients should look very different than non-transplant patients. And I think we should actually aim for hard clinical outcomes rather than surrogate outcomes in transplant patients.
Right, so it's not like how we do in NASH, where we look for advanced fibrosis. This one, in this case, we'll be more looking at cirrhosis, mortality, things like that.
Yes, exactly. Because unlike the non-transplant population, these patients are at such high risk that you don't actually have to wait that long for them to have events.
Okay. And with the recent change in nomenclature from NASH to MASH and henceforth, how does it affect like transplant? And what we have done so far?
Yeah, so I think you've done a lot of great work on this nomenclature and how it affects the overall world, the metabolic world, the non-transplant world. I think in the transplant world, we're sort of still trying to figure out how it affects it, because even before the nomenclature change, I think the way things were being entered into the UNOS database, which is what sort of the central database is for all transplants in the United States, there was somewhat inconsistencies in how patients were put in there. So I think we still have to wait and see how this plays out. But I think there can be some very interesting studies that can be designed looking at using the UNOS database in the future to see what the true impact of the nomenclature change would be on the transplant world.
Right. But I think that UNOS doesn't have the clarity in coding that is required for MASH.
Yes. So they actually still classify it as, a lot of patients classify it as cryptogenic cirrhosis, or solely classified as hepatocellular carcinoma may actually have underlying NASH.
Right. And I think the demographics coding in UNOS is, if I recall, is not as it doesn't allow us to look at LDL levels and things like that. So it would be like a surrogate of a surrogate. Like there's hyperlipidemia, therefore we conclude that these patients are likely MASH related.
Right. And like all of these databases, the thing is that the data is only as good as the data that get put in. So the output is entirely dependent on input. And unfortunately, there's no central way of that everybody's validated that the entry is being done the same way at UCSF, that is being done in Charlotte, that's being done in Virginia, that's being done in Chicago, So that's the issue. There's not a consistent way of doing it.
Right. Definitely that's an issue. So I guess, moving from here, we should definitely look at us, like how the 3.0 is affecting NASH patients, and potentially we can look into some biomarker development in transplant patients, like you mentioned.
Yes, and I want to highlight one very beautiful study that was done by a colleague of ours, what she did is she looked at patients who get a transplant for NASH cirrhosis, but they get the organ from a diabetic donor. And we all know that patients who have diabetes are more likely to have fatty liver disease, right?
Right.
So she showed is that, if the number of diabetic donors in the United States have doubled over the last 10 years. And if you take a NASH patient and you give them a diabetic organ, that their survival within 3 years is significantly lower than patients who received an organ from a non-diabetic donor. So, it raises all sorts of questions about, what can we do to match these organs better? Because you don't want your patients to die within 3 years because they got the wrong organ. And I think it really highlights that we need to do a much better job of matching the organ to the patient. Because if we're making that big of an investment in a patient, we want a lot more than 3 years. We want them to live 20, 30 years.
Right.
It was a very beautiful study done by when you.
The study that we did in transplantation.
Yes.
Yeah. Okay. Thanks so much, Prof, for your time. So, thanks for joining us today and sharing your views on NASH transplant. We hope to have you back another time, maybe in the future, looking at other things in NASH.
Absolutely. My pleasure, Singh. Thank you for the kind invitation.
Thanks, Prof.
We have come to the end of the episode. Thank you for joining us, and stay tuned for more captivating discussions.